Good morning, everybody. I'm very happy to start our day with that song because it's the everyday people that are going to make this plan a reality. And I am so excited to be here with you all this morning. Welcome, everybody, to the third of four strategic plan launch sessions for the Illinois Community-Based Birth Justice Strategic Plan. My name is Anna Yankolev, and I will be your host. I am the Director of Strategic Workforce Initiatives at Health and Medicine Policy Research Group, and I've been working closely with the Black Midwifery Collective to facilitate the strategic planning process and develop the plan itself. Over the past year and a half, dozens of community-based birth justice workers have supported the development of a new strategic plan that works to ensure that every birthing person in Illinois has access to the community resources, settings, and support that they need for a safe and positive perinatal birth experience. Simultaneously, several researchers conducted studies, focus groups, and key informant interviews with community-based birth workers to better understand their barriers, needs, and priorities. These findings together help to inform the key themes that shape the evidence-based foundation for the strategic plan. In this four-part webinar series, we will review the findings from these different research projects and culminate in an overview and release of the strategic plan during the final session next week. You are welcome to join for any combination of these webinars based on your interest and availability, and we, of course, will make recordings of all the sessions available after the series concludes. Today's session features two research projects that explore the impact of racism and discrimination on Black birthing people. While our first two sessions focus more on the realities facing doulas, midwives, birth centers, and other roles that support community-based birth justice, including community health workers, peer support workers, social workers, clinicians, and others, this one focuses on how our current systems impact the health and well-being of Black birthing people in Illinois. After we go through some housekeeping, we will review key terms and provide a brief introduction to birth justice and why this work is so critical. Then, Nicollette and Star will each go through their research to share their findings and recommendations. We hope to have about 15 to 20 minutes at the end for a lively Q&A. For those of you who joined us for the first two sessions, the next 7 minutes or so will be pretty much the same as to what I've shared previously, so feel free to go refresh your beverage or finish up that email while we catch everybody else up to speed. Couple housekeeping notes. Please introduce yourselves in the chat if you haven't done so already. We'd love to know who you are. We are recording these webinars and we will be translating them into Spanish, and everything will be available on our YouTube channel after the fact. And as I said, we will have a Q&A session at the end of the presentation, so please be sure to put your questions in the Q&A function at the bottom of your screen rather than in the chat. A quick review of some key terms so that we are all working from the same definitions. When we say perinatal, we're talking about the period of time from when someone becomes pregnant to up to a year after giving birth. Community-based is the relationship-based perinatal care that occurs outside of our health and hospital systems. And when we say birth justice, we are referring to the right to choose whether or not to carry a pregnancy, the right to choose when, where, how, and with whom to birth, and the right to breastfeeding support. And we are, of course, ever grateful to Jamara Amani for this definition. And a note on gendered language: while we strive to use gender-neutral language wherever possible to describe birthing people, we do use gendered terms like maternal or women when referencing research that utilizes those terms. So, why do we need this plan? Because Illinois has a big problem. Not every birthing person has the same opportunity for a safe and healthy birth experience, leading to serious injuries and death that are often preventable that impact some communities more than others. Avoidable and unfair differences in health outcomes like these are known as health inequities. We believe that we need to achieve birth justice in order to eliminate these health inequities. So, which communities are more likely to experience perinatal health inequities? Black women are more than twice as likely as white women to die from a pregnancy-related cause. And in Chicago, that number jumps up to 6.5 times as likely. Black women are also more than twice as likely to have a potentially life-threatening condition or complication that occurs during labor and delivery when compared to white women. And this is the focus of our session today, is these inequities that are that we're seeing particularly among Black birthing people over other populations. And it's important to note that while there have been improvements to mortality rates for birthing people overall, the rates for Black people have stayed the same or have even worsened over time. Women on Medicaid are more than 3 times more likely to die from a pregnancy-related cause than women with private insurance, and it's important to note that 40% of all births in Illinois are covered by Medicaid. Older women, over 40 years old, as well as women with a high school education are more likely to die from a pregnancy-related cause than their counterparts. And notably, 1 in 3 deaths occur during pregnancy, and 1 in 3 occur more than 60 days postpartum, meaning that the majority of maternal deaths are not occurring during labor and delivery. And importantly and horrifically, 9 in 10 pregnancy-related deaths are at least somewhat preventable. And this statistic right here is ultimately what we are trying to change. And our strategic plan explores what we can do to help eliminate these preventable deaths and promote the health and vitality of all birthing people. So what causes these inequities? For many people, especially those from communities of color, immigrant communities, and rural communities, accessing comprehensive perinatal care in health and hospital systems can be difficult or even dangerous because not everybody can get the care they need, either because they live in a perinatal care desert, like residents of 1 in 3 Illinois counties, or because they can't afford the care they need. There also simply aren't enough workers to meet the demand, either in health systems or in community spaces. And our first 2 sessions discuss this much more in greater detail if you'd like to learn more about that. Racism and discrimination prevent many people from seeking or receiving care, and many women report experiences of dismissal, discrimination, and disrespect due to their race, insurance status, immigration status, age, or substance use. And that's the focus of our session today. Many birthing people also have pre-existing or new medical, mental health, or substance use issues, and these are issues that need dedicated care beyond the walls of the delivery room. And those struggling with access to health care, safe housing, healthy food, reliable transportation, livable wages, childcare, and other factors known as the social determinants of health also report worse maternal health outcomes. Many birthing people must navigate multiple of these barriers to get the care they need, and often these barriers impact and intersect with one another. This can make the conventional perinatal system inaccessible and in some cases harmful for birthing people, particularly for communities most impacted by maternal health inequity. And we believe that community-based birth resources and supports can help address these barriers and advance birth justice. Our strategic plan, to be released next week, we're almost there, provides lots of evidence as to how community-based birth resources and supports, either on their own or in combination with health and hospital systems, are proven strategies to improve health outcomes for birthing people, reduce barriers to care, and reduce healthcare costs. So I'm not going to go into all of that now. You can join us next week for a deeper dive into that data. But we do know that we have a long way to go before we can ensure that everyone has access to the community-based resources and supports that they need and deserve. Our session today, Racism, Discrimination, and Their Impact on Black Birthing People, will dive deeply into the dangerous consequences that these forms of bigotry have on the health and well-being of birthing people and those who support them. I'm going to introduce both of our speakers now, and we will start with Nicolette's research and then move over to STARS. We will address all questions from the Q&A at the end, so please be specific in your question if it's for a particular researcher. Nicollette Moore has a master's degree in public health with a concentration in maternal and child health and program evaluation. She has 8 years of experience leading and supporting projects advancing maternal and reproductive health equity. Nicollette currently works at the Northwestern University's Feinberg School of Medicine, overseeing the daily operations of community-centered maternal health equity projects at the Social Environment and Health Lab. Star August Ali, known affectionately as Sister Star, is a Black midwife, mother of four, and nationally recognized leader of birth justice with deep roots in ancestral Black midwifery traditions. A descendant of a grand midwife who practiced in the 1940s, Star brings generations of wisdom into modern midwifery practice. She's a certified professional midwife and licensed midwife in Illinois and is currently only one of 4 Black CPMs licensed in the state. Prior to licensure, she practiced for 3 years under Illinois' former restrictive laws at great personal risk so Black families could access safe, out-of-hospital care aligned with their values and lived experiences. Star is the founder and executive director of the Black Midwifery Collective, a Black nonprofit based on Chicago's South Side dedicated to improving maternal health outcomes and rebuilding the Black midwifery workforce, and chair of the inaugural Illinois Midwifery Board. I want to especially credit Star for her leadership in the community-based birth justice strategic plan. We would not be here having this conversation today without her. So, Nicollette, take it away.
All right. Thank you so much, Anna. So, funded by the American Heart Association, the Dismantling Structural Racism to Promote Equitable Maternal Health Outcomes, which we more commonly refer to as the DREAM Study, is a part of the P3 Equate Health Equity Research Network. The DREAM Study is led by Dr. Kiari Kershaw, a social epidemiologist who oversees the Social Environment Health Lab, which is housed within Northwestern University's Feinberg School of Medicine, Department of Preventative Medicine. To quickly provide an overview on the purpose of this study, the DREAM study seeks to better understand how structural racism influences Black maternal health outcomes, experiences, and birthing journeys. The long-term goal for this project is to create a set of community-centered, actionable targets that reflect the lived experiences and needs of Black pregnant and postpartum birthing people, and can be used to reduce the negative impact of structural racism on maternal health equity. So, as previously mentioned, the study is led by Dr. Kiari Kershaw. And to quickly introduce some of the other study team members, we have Lauren Hoffer, who's a research project manager and provides IRB oversight. We also have Latasha Rouse, who is an expert advisory panel member, which I'll talk about a little bit more about in a few moments. And she's also one of our community consultants. Then myself, as Anna has previously mentioned, is the research project coordinator, and I oversee the daily operations of this project. We also have a postdoc, Dr. Marissa Cisneros, who is also supporting with manuscript write-ups of our data analysis findings. And then lastly, we also have Dr. Tiwalde Adukule, who is a former postdoc who has also provided a vital role with data analysis and the write-up of manuscripts. So there are 8 Black women who all share an invested interest in Black maternal health and maternal health equity, and they serve as our expert advisory panel. These women come from diverse backgrounds, such as academic, research, and clinical settings, and they provide us with strategic oversight suggestions on how we can move forward and advance this project. So, in terms of the study methodology, we initially sought to hear from Black pregnant and postpartum birthing people to ensure that we prioritize their direct lived experiences. And through these conversations, we learn the importance of community-based support because then it can play a vital role in one's birthing journey. We also learned too that there are many challenges with getting connected to and using community resources. And in order to have a multi-tier holistic approach, we also decided to expand the folks that we are talking to ensure that we have a comprehensive understanding of this complex issue. This also led us to conducting interviews with leaders and staff members of community-based organizations, which I'll also be calling CBOs. And then we also conducted focus groups with community-based perinatal providers, which I'll also be referring to as CBPs. After we analyzed the data, we also hosted what we call shareback sessions. So these sessions are meant to really share back what we heard through our various conversations with former participants. We do want to prioritize and ensure that we are accurately capturing their lived experiences and the perspectives that they're sharing with us. And in order to honor that, we want them to be the first to hear the findings and to make sure that we are accurately capturing that and to provide us with suggestions, especially if they disagree or they think there's modifications that need to be made. After we host the shareback sessions with former participants, we also do a similar thing with our expert advisory panel, in which we share back our findings so far, as well as the feedback we received in these shareback sessions. And again, we want to ensure that we are accurately capturing and continuing to ensure that we are honoring their lived experiences, and also for them to provide additional suggestions that maybe we have overlooked. So really quickly, I want to go over the inclusion criteria for birthing people, community-based organizations, and community-based providers. So for birthing people, we did ask that they're 18 years or older. They self-identify as Black or African American. They're currently pregnant or postpartum, which we define as having given birth up to 12 months ago. And they resided in one of the following states or areas listed on the screen. And the purpose for this is that these are where our support came from in terms of having various community consultants who assisted us due to their connections to the community. So we wanted to ensure that we can tap in and hear from diverse perspectives, not just geographic location, but also socio-economic background too. In terms of community-based organizations, again, asking that folks be 18 years or older. They work in the United States. They either have a leadership position or a frontline worker position. In terms of a leadership position, we are defining that as someone who either oversees staff or a project. And then in order to be a frontline worker, we're defining that as someone who is providing direct services and support and guidance to clients. We also ask that the organization have Black pregnant or postpartum clients that they serve. And they're providing services that address one or more of the following domains of structural racism. So that includes health, public health, housing, education, employment, criminal justice, neighborhood development, and economic investment. And then lastly, for community-based providers, again, being 18 years or older, working in the United States, they have to be providing perinatal services in community-based settings. So we were wanting to look at folks who are working outside of the hospital system. And their clientele includes Black pregnant and or postpartum clients. And when we're talking about community-based providers, we are talking about folks who work as birth workers, community health workers, doulas, home visitors, lactation consultants, midwives, mental health professionals, and providers of substance misuse care. In terms of the structure of focus groups and interviews, all of our focus groups and interviews are held virtually via Zoom. They are audio recorded and professionally transcribed at a later date to assist with data analysis. They're all facilitated by Black women. And then we also have a research assistant who typically attends these meetings, not only to help with logistics, but also to take field notes. And then before we jump into any interviews or focus groups, we find it important to always go over the study purpose, guidelines for being together if we are conducting focus groups, and then we want to give them the opportunity to ask us questions. And then once we get their consent to record, we then start the focus group or interview. So in terms of data analysis, we really wanted to ensure that we are applying a structural racism lens. And so in order to do this, we wanted to find a definition that we felt was comprehensive of a very complex topic in order to guide data analysis. So we decided to use one of the more common and popular definitions of structural racism, which there isn't actually a formal one, which was written by Bailey et al. In 2017. And they define structural racism as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. These patterns and practices in turn reinforce discriminatory beliefs, values, and the distribution of resources. And we did use grounded theory to identify manifestations of structural racism. And we also utilized triangulation methodology to increase validity. And so what we mean by this is that we wanted to engage with multiple perspectives and incorporate different lived experiences throughout data analysis and the interpretation of findings. So that included not only the study team members who were analyzing the data, but also in the shareback sessions when we were sharing them back with former participants, and also our expert advisory panel when we would share back findings as well as the feedback we received from former participants. So with data analysis with community-based organizations and community-based providers, we use the manifestations that we identified from focus groups and interviews with birthing people to guide data analysis with these two groups. And using thematic analysis, we refined manifestations based off of the specific stories and lived experiences that CBOs and CBPs provided, but then we also tried to identify new manifestations. Something that we really wanted to take the opportunity to do is not only their perspective on how structural racism impacts their Black pregnant and postpartum clients, but also how do they perceive structural racism to impact the work that they carry out. And then again, we use triangulation methodology to increase validity. So again, wanting to engage with multiple perspectives, including the study team, former participants, and our expert advisory panel. So really quickly, I want to go over demographics of who exactly participated. We have a total of 147 people who participated, 100 of which were birthing people. Most folks were postpartum at that time at 62%, followed by 38% who were pregnant. In terms of educational attainment, most folks had a master's degree, followed by having a high school diploma or equivalent, and also some college, but no degree. We also had 14 members of community-based organizations participate. A majority of them had leadership positions, and then a few also were frontline workers. We also asked them about the types of services that they provided. They could select as many options as they wanted. Everyone that we engaged with provided health services, education, or support, and then followed by financial services or income assistance and family child care or education programs. And then lastly, we had 33 community-based perinatal providers also participate. 75% identify as Black or African American, followed by 19% who identify as white, and 6% who identify as Asian or Pacific Islander. Now, in terms of the type of CBP they identified as, and they could select as many options as they wanted, we engaged the most with people who work as doulas or birth workers, followed by midwives and lactation consultants. So before we jump into the findings, something that we think is important to highlight is that we do want to acknowledge that the impact of structural racism varies within the Black community, and each birthing person's experiences are unique. Our findings are a reflection of the lived experiences and perspectives of people with diverse backgrounds who come from different socioeconomic and geographic settings. The first manifestation of structural racism that we want to address is obstetric racism. And this is a topic that we heard across all three groups that we engaged with. And when we're talking about obstetric racism, we're talking about people feeling unseen and unheard. Healthcare teams are not following birthing plans, they're not respecting wishes, and they're not engaging in shared decision making. Also feeling pressured to accept treatment or service options, such as having a C-section, having an induction, using pain medication during delivery, or going on birth control after giving birth. Black pregnant and postpartum people are also experiencing racialized stereotypes. So assumed to be a single parent, which when they had their partner who was working or had a schedule conflict, they would go into their clinic, and then their provider or their healthcare team assumed that they didn't have any support, and they were experiencing judgment for it, or being assumed that they couldn't afford treatment or service options, which sometimes led to those treatment or service options not being offered. Assuming that they're not going to breastfeed, so they don't provide them support or information, having a higher tolerance to pain, or misusing substances. And to illustrate this example, to the right is a quote from one of our birthing participants who was talking about feeling like nobody was listening to her. And while she was experiencing this, she was reflecting on Black maternal mortality rates and how Black women are assumed to have a higher tolerance to pain, as she felt that her anesthesiologist was not listening to her and she was experiencing discomfort. We also found there was an inequitable distribution of resources and services within healthcare settings. There is a perceived racial disparity in who maternity care providers share resources and service with. White birthing people are more likely to receive needed information during healthcare visits compared to their Black counterparts. And in turn, Black birthing people are having to engage in self-research. They're having to rely on their peers, their family, their community for guidance in order to find needed resources and services. And this creates a lot of challenges with actively participating in their care and being able to make informed healthcare decisions with their provider. Within our shareback sessions, this has probably been the most controversial topic, notably because those who work closer with healthcare professionals think that without quantitative data, we can't really say that healthcare providers are purposely not sharing resources. And so, because of that, there is this conflict in which we're trying to find a balance because many of our birthing people do believe this. They did share it with us. Um, and one of the things that we want to highlight to illustrate this is one of the birthing people who participated talked about feeling like you have to research things on your own in order to get information because it isn't offered upright. And she actually was pregnant at the time with one of her white coworkers. They had the same healthcare provider, but yet she noticed when talking with her that she seemed to have more information. There was also an issue with inequitable distribution of resources and services in community settings. So living in under-resourced communities can create barriers to accessing needed resources and services. And there's a variety of reasons for this. It includes availability, proximity, and knowledge of existing programs. And these communities have been purposely disinvested in as a result of structural racism. And within these communities, there are disparities in accessing needed resources and services, such as food, for example. Sometimes they have to travel far distances to access a grocery store. And if they don't have a car or they don't have access to a public transportation, it creates a lot of barriers. Or they could live near a grocery store, but they're finding that the food quality is low. And so they have to travel further distances in order to get high quality food. There's also issues with public transportation not being readily available or going to where they need, as well as housing. Specifically talking about public housing, where wait times are long, the housing quality is low, and sometimes it requires them to move out of state in order to access housing sooner. As reflected by one of the community-based organizations we spoke to, she talked a lot about bereavement support and specifically that there's a lot of chronic disinvestment in their communities and that where there are more people of color, there are less likely to be bereavement support and how this is purposely a reflection of structural racism. We also heard issues with policing Black families. Black birthing people are being reported or threatened to be reported to Department of Human Services or Child Protective Services. This is mostly occurring within hospital settings and from birthing people as well as community-based organizations and community-based providers who have witnessed this. These reports are perceived as extreme, unfair, and reasons vary. Um, it includes being perceived as being non-compliant, declining vaccinations for their child like eye care cream, or thinking that they're using substances. And we have two quotes to kind of illustrate this point. So one is from a community-based organization who is talking about how it's really hard for the families that she supports to stand up and advocate for themselves because there are policies in place in which they want people to act a certain way with their newborn and the mom to act a certain way. And if you don't fit that, they're going to call CPS. We also had a participant who talked about going to a hospital. Her child was sick. She had her other child with her. And the provider, instead of providing care, was questioning her why her other child was with her, why the child wasn't with another family member, and ended up reporting her. And her child did get separated from her from some time. She had to switch out to another hospital, and that healthcare team helped her get reunited with her child. And as I previously mentioned, we also wanted to hear how is structural racism impacting community-based organizations as well as community-based providers. So one manifestation of structural racism that we found is that there are system failures that really limit the ability for community-based workers and organizations to carry out their work. And this can look in a variety of ways. One of those ways is that birthing people have limited awareness of available services and support available. There's also inadequate compensation for the time, effort, and work provided. Training and education requirements among certain community-based providers can be costly, or it doesn't provide them with the knowledge and skills that they need to support clients, especially when it comes to anti-racist curriculums. There's also a disinvestment of community infrastructure, which creates barriers for connecting clients to needed services that go beyond their scope of service. And something that we heard quite common among community-based organizations is that oftentimes they have to expand their scope of service that wasn't necessarily relevant to the mission because they have to try to find a way to meet the needs of their clientele. And it creates a lot of barriers because it's difficult. It's difficult to find funding. It's difficult to figure out how they can go beyond that scope. And one of the community-based organizations that we talked to talked about this and how it is really hard to rise above these systems that are failing not only their clients, but also these organizations who are trying to support their Black pregnant and postpartum clients. And that it makes it and then it makes it extremely hard for them to be able to engage and do this work. They also talked about this perceived value of community-based work. So a lot of this is reflected in funding or lack thereof. One, they find that there's a lack of funding for Black maternal health initiatives. There's also a lack of funding and financial support for community-based providers who are doing the groundwork and have been doing the groundwork for many, many years and are being overlooked. There's also limited funding for smaller community-based organizations, especially when we're looking at grant requirements, in which sometimes smaller community-based organizations feel like they're more interested in numbers and being able to have unrealistic expectations of seeing this change. And a lot of these CBOs are doing amazing work, but because they're not engaging with enough clients or they're not seeing fast enough changes within a year or two, they're having trouble getting that funding. There are also community-based organizations led by people of color who are facing more barriers securing funding compared to their white counterparts. And many of the people in leadership positions talk about how they need to have white allies in order to get their foot into the door, in order to be listened to. And then amongst community-based providers who are working or engaged with the hospital system, such as doulas, it can be really difficult, aggressive, and hostile working with hospital care teams at times because they don't value the work that they do and they think that they're trying to undermine their work. And one of the community-based providers we talked to talked about how there is a lot of funding, but it's going to things like new state doula programs. It's going to virtual telehealth perinatal programs. And these are new organizations that are popping up saying they're addressing Black maternal health crisis. And there's also a lot of people who aren't doing the work, but they're receiving a lot of money to do this work. And it's directly impacting Black pregnant and postpartum individuals. And as I've mentioned, there are many people who are doing that groundwork who are being overlooked. There's also this emotional impact. And although this wasn't a huge finding, we do find it very compelling because people are talking about how they are experiencing secondary trauma and burnout from engaging in this type of work. So they're not only trying to support their clients, but many of them also reflect the communities that they're serving, and they do not have the resources to be able to support themselves mentally. But we also have people who are talking about the resilience of the Black community too, and about the importance of finding ways to develop self-care tools and build a professional community to mitigate these negative impacts. And one of the community-based providers that we spoke to talked about how there is so much resilience in the Black community. And even though they are facing secondary trauma as well and burnout and trying to support and uplift people with the same lived experiences, they do know how to take care of themselves. They know where to find relief, and that is reflected in ancestral history that has been proven over and over again. And lastly, we want to go over some recommendations that we have heard from birthing people, community-based organizations, as well as community-based providers. So we asked them what they think needs to happen in order to mitigate, disrupt, and address structural racism. Some of the things that we have heard include provide education to birthing people about their rights and self-advocacy, which is incredibly important to the birthing people that we have spoken to, as well as the availability of resources, connecting them to available resources, and trying to find ways to break down those barriers. But also what's important is expanding postpartum care, maternal mental health, and perinatal transportation services. Among CBOs and CBPs, it's also important to diversify the workforce to ensure that those needs are being met and reflect the communities being served. Also important is to streamline cross-sector collaboration and communication. The community-based organizations and CBPs that we spoke to who were able to connect with other organizations found that they were able to provide needed resources to their most marginalized clients. And then lastly, expanding out of hospital options. Many of the birthing people that we talk to who experienced a traumatic birthing experience said that they don't want to go back to the hospital, but it's really difficult to find sources outside of that. There also needs to be more anti-racist birth worker curriculums that address community needs and are ensuring that high quality resources are readily available.
All right, so my name is Star August Ali. I'm an executive director and founder of Black Midwifery Collective. Our aim is to grow and diversify the midwifery workforce. We believe Black midwives save lives, and we ideally want a midwife in every neighborhood, not only in the US, but worldwide. The community birth study conducted in 2022 and funded by the Illinois Department of Public Health through the Exploring Alternative Healthcare Delivery Models for Birthing Persons grant. This content and opinions expressed in this presentation are the author's own and do not reflect the view of our funder. With this study, we wanted to, number one, gain insight into the unmet needs of birthing people on the South Side. Number two, amplify the lived experience of people living through OB closures and disproportionately high infant and maternal mortality rates that follow along racial lines. And number three, we wanted to learn whether the national trends and increased demand for midwives and out-of-hospital birth was true on the South Side of Chicago. We were the lead organization with Nora Kopp and I as co-lead investigators on the study. In addition, we had Chanel Haley, formerly at Tulane University, now at the University of South Carolina. We also had Nicollette and Chiari at Northwestern University, who also presented in this webinar. The study team would like to acknowledge the following people who contributed to this study: Kaylin Jarris, Mecca Zenix Alexander, and Aquila Graves of Benia, who supported the focus groups and were instrumental in recruiting survey participants, and Ella Schneider of DePaul University, and Alicia Harley at Intuit Work. The Community Birth Survey collected patient-reported data. The questionnaire was accessible to participants from August 22nd through December 22nd through online platforms, specifically Qualtrics. The survey was distributed in both English and Spanish. The convenient sampling method was used for recruitment. Community birth workers conducted our outreach for study recruitment that included a mix of in-person events and post-media with printed advertisements displayed at public health, perinatal, and WIC clinics, complementary retailers and childcare centers, local birth workers, i.e. doulas, childbirth educators, lactation consultants, and childcare centers, and broader community centers and events frequented by parents of young children who reside in the study area. The advertisements, both printed and digital, provided a QR code directed to a landing page with information about the study, inclusion criteria, screening questions, informed consent documents, and the survey. Respondents had the option to take the survey on site using a study tablet device with help from study staff, or to take the survey at the location and time of their choosing using their personal device or smartphone. Focus groups results did not produce saturation and therefore are not used here to show scientific results, but are used to provide detail and context to the survey results. We conducted 2 focus groups of 6 to 8 birthing persons from the study area and 1 focus group of 7 birth workers who work in the study area. Birthing persons focus group participants were recruited from after the survey. After completing the survey online, a screen appeared giving details about the focus groups and asking respondents if they were interested in participating in a focus group related to the survey. The birth worker focus group used a convenient sample of people known to our organization and were recruited using a snowball method. People eligible for the birth worker focus group had to be 18 years of age or older, identify as a person of color, and work with birthing persons in the study and catchment area. Birth workers were doulas, lactation consultants, childbirth educators, and birth assistants. 6 of the 7 birth workers identified as non-Hispanic Black women, and 1 identified as a Hispanic non-Black woman. All focus group participants underwent an informed consent process, and focus group discussions focused on 2 clusters of questions. The first series of questions centered on perinatal health, care received, and the barriers and facilitating factors to access care. The second series of questions pertained to the awareness about and the acceptability of the use of community-based, out-of-hospital perinatal health care and supportive service. Moderators for the focus group lived in the study area and were knowledgeable of and sensitive to the cultural landscape in perinatal health in the study area. A community advisory group, also known as CAG, was formed during the course of the study to center community voices during the research process. The objective of CAG was to ensure our proposed research aims and methodologies approaches align with the communities we serve. Group members all identify as Black women and were recruited from reproductive and birth justice grassroots organizations in the study and catchment area and from birth worker focus group participants. The CAG met multiple times to discuss the research questions, data findings, and gave context to the numbers. They helped categorize written responses on the survey, reviewed and commented on the data output, and on the final draft of the report. The group was facilitated by Khadisa Say and was comprised of members of Megazin Alexander, Shaquan Dupart, Deanna Bessette, and myself. Next slide. This was an IRB-approved study. Eligible participants were adult, 18 years or older, birthing people who have given birth at least once, with their most recent birth occurring on or after January 1st, 2018, and residing in the 44 zip codes comprising the study and catchment area during the time of pregnancy and birth. Next slide. The survey took about 30 to 45 minutes to fill. Upon informed consent, respondents provided responses to questions pertaining to their demographic information, i.e. race and ethnicity, payer type, Medicaid versus private insurance, parity, zip code of residence during pregnancy and birth. Questionnaire items regarding a respondent-specific perinatal events and experience were divided into 3 sections. Number 1 being pregnancy, number 2 intrapartum labor and birth, and number 3 postpartum. Respondents were asked to keep their answers specific to their most recent pregnancy that resulted in childbirth so that the measures could describe the same episode of care. Next slide. A total of 454 people filled the survey. 60% used Medicaid or CHIP, and 36% reported that their income was not sufficient to meet their needs. Next slide. The Medicaid use and racial demographics of survey participants closely mirror demographics of the South Side population. The same is true for racial and ethnic breakup of study participants. About 3 out of 4 of the study respondents were Black, 13% were Hispanic, and 11 were white. Next slide. The majority of participants had vaginal births at 73%. 20% of the participants birthed their babies via C-section. The C-section rate was slightly higher compared to the rate of cesarean sections overall in Illinois at 21.5% in 2019. Next slide. The majority gave birth in a hospital setting. If you add up the 3 columns in the right, birth center in a hospital, freestanding birth center, and home birth, you will see that number. You'll see that 17% of the survey respondents gave birth outside of a traditional hospital setting. Next slide. So as I mentioned, 17% of the respondents gave birth in a hospital-based birth center, a freestanding birth center, or at home. However, when asked if at all settings were equally available and affordable, which birth setting would be most ideal, only 35% replied a hospital would be ideal for them. 61% identified their ideal birth setting would be in an in-hospital-based birth center, a freestanding birth center, or at home. Specifically, 25% wanted an at-home with a doctor or a midwife. 28% wanted a birth center inside of a hospital, said a hospital would be ideal, and 8% said a freestanding birth center would be ideal. A key message that we want to highlight is that the demand for community-based birth settings and the demand for midwives was 3 times that of what is currently available to the survey participants. This represents a great unmet need in our community. Next slide. Similarly, 10% of the respondents had a midwife as the primary attendant at their birth. However, when asked how open they would be to having a midwife as their maternity care provider for their future pregnancy, 36% noted they would definitely want a midwife. A key message that we want to highlight is that the demand for community-based birth settings and the demand for midwives was 3 times that of what is currently available to the survey participants. This once again represents a great need in our community. Next slide. Black birthing focus group participants highlighted why some people may seek out alternative healthcare models outside of the hospital system, including fear of outcomes their families, friends, or they themselves have faced in the past in a hospital setting. For instance, this one participant noted, "I never understood what was the fascination with cutting open Black women to get their babies out unless it was in dire need, right? But people that I know is completely healthy going into hospital to give birth, and when they come out, they get cut open. So when I got pregnant, I wanted to have her at home." Next slide. Conversely, one could say that only a 36% demand for midwives could be considered low. One community advisor group member who is a Black birth worker talked about the need for more information and awareness about the midwifery model of care in order for community members to make informed decisions on the type of maternity care they choose. This specific member said, "They weren't educated to know midwives are an option. Historical racism against Black midwives took away historical knowledge about midwives. What are the kinds of things that were said about Black midwives? Dirty, dangerous, unskilled, etc. A lot of women don't know the benefits because the hospital system instills so much fear." Next slide. Results from the survey found that more Medicaid users always or almost always saw the same clinician for all of their prenatal appointments when compared to using private insurance. This can point to a measure where the public health system is doing a better job than the private health care system of matching pregnant people with the same provider or a small related group of providers throughout their care. Answering why this is beyond the scope of the study. However, in conversations with FQHC providers expressed that the public health system has an expectation that people will need to reschedule appointments, and thus their system is built around keeping their clients with their primary provider despite frequent rescheduling of appointments. The type of provider may be another factor, especially if people using Medicaid are more likely to be paired with a medical student or resident who requires continuity of care to fill their residency requirements rather than a senior doctor or OB. Next slide. Evidence shows that higher racial, cultural, social congruence can improve outcomes, especially for Black patients. In our study, only 28% of respondents said their primary provider shared their racial identity. When we looked at the respondents overall, about 25% said culturally congruent care was important to them. But when we looked at this by race, the number doubled. Over 50% of both Black and Indigenous birthing respondents said that having a provider who shared their racial and/or ethnic background was very important to them. Next slide. IDPH has reported that discrimination, including structural racism, contributed to 39% of pregnancy-related deaths during 2018-2020, and that discrimination was more likely to be a contributing factor to pregnancy-related deaths amongst Black women than birthing people of other races. In our study, when asked about their beliefs about healthcare environment in Cook County, people said 70% completely or mostly agreed with the statement. I believe providers in Cook County treat white pregnant women with more respect than women of color. 50% completely or mostly disagreed with this statement that mothers who use Medicaid versus private insurance are treated equally by hospital personnel. 60% completely or mostly agree with the statement. Local healthcare providers show less concern for the well-being of pregnant women if the women are poor or have low education. Next slide. A doula focus group participant who has worked in many hospitals all over the city for years talked about the suffering that results when Black birthing people are more likely than their white counterparts to be cared for by medical students and more junior, less trained doctors. They're putting medical students or untrained doctors in situations and scenarios that are very risky and very dangerous, but only with particular demographics, right? So if you come in and you have a medical card, they're going to give you whatever, right? And you know those mothers and those babies end up suffering as a result. One other participant said, who happened to be one Black birthing person, who shared how 2 generations of her family, including nieces, aunts, siblings, and her mother, without exception, had all been subject to C-sections by the same family doctor. My mom had a C-section with me. My nieces were twins, so my sister had a C-section. Each twin had a C-section the first birth. Are we naming names? Because I can think of a doctor, and I know she's very talented at C-sections. I think she really just likes doing C-sections because she birthed my whole family. Like, she cut open my whole family. And we heard on the flip side too of this too, wherein a Black birthing mom had the majority BIPOC birthing team that advocated for her through giving her inner strength in labor and spared her the chore of having to prove and demand she deserved dignified care or the fear and frustration of being unheard. I felt listened to. The questions I had, they answered them without any issue. I had a diverse team, which I think was nice. It was majority people of color, and even kind of late on laboring, hearing the kind of advocating behind the scenes was kind of dope. Next slide. There are many more intriguing results included in the full study, and we are encouraging folks to read the study available on our website. You can reach it at blackmidwiferycollective.org. We'll have more information about it. Overall, we would like to conclude the discussion of our results by saying we saw layered, often competing factors which played into the complexity of people finding or accessing desired care. Participants often spoke of having to make a choice when the choice they wanted was not available. And this really leads to the iceberg effect, as you guys can see. We have a doula fix, quote unquote. Obviously, doulas are being pushed as a solution in the maternal health crisis in the US. We have narrowed pathways to education, and we have a huge midwifery shortage. I know most of you guys are aware there were 2 birth centers that closed in the state of Illinois due to a midwifery workforce shortage, and there is a very short amount of midwives working in a community-based setting. And this is all leading to increase in preventable maternity infant mortality. And some of the more and other barriers that we have in Illinois is obviously, that we have an abundance of closures of OB units and on the south side and throughout the state. We have maternal health deserts all over the state of Illinois as well, fragmented prenatal care, siloed reproductive abortion and birthing care, limited service options for Medicaid recipients. I know someone in the chat mentioned a lot of people wanting community-based births, but not being able to access community-based providers because of having to either pay out of pocket or not being able to bill. That is something that we are working on. BMC is actually negotiating with the state. We're waiting for that to roll out. We also have limited mental health services and high rates of policing or family separation of poor people, people of color, and people who struggle with addiction. Next slide. So what are some of the solutions? Obviously, that we talked about the midwifery model of care came up a lot in the conversations based on what we were hearing from the study participants. Just to talk about a little bit more, the midwifery model of care centers community-led births and collaborates to reinstate midwives as primary care providers available in hospital and community-based settings. And this is really important because Only 8 to 10% of births are deemed high risk and need an upper level of care, which means that 90% of the population can receive care from midwives, care from midwives. Next slide. And on a national front, we are having national calls to action to invest and grow and diversify the midwifery working force. From the White House Blueprint of 2022, experts suggest that disparities in maternal health outcomes could be reduced by increasing workforce diversity and having more culturally congruent maternity care in the United States, with healthcare providers of color helping to mitigate cultural barriers in the healthcare system. Midwifery can play a particularly important role in understanding a community's traditions and providing culturally appropriate care. Consequently, our work in this space must remain laser focused not only on workforce expansion, but also on the diversity that will assist this expansion and ensure that the entire maternal healthcare workforce looks like America. And from the National Partnership for Women and Families of 2022, this particular study, expanding access to care in community birth settings is a cost-effective solution to providing higher quality care and better birth outcomes, and with an intentional focus to advancing birth equity. Next slide. We cannot cover every aspect of this study, but as midwives, we present this solution because we are aware from both national and international evidence that community-based midwifery models offer a viable approach to confronting the alarming data that is well documented. Black Midwifery Collective and Kennedy King College are thrilled to announce that our proposal for the first certified professional CPM degree program in Illinois has been approved by the Joint Curriculum Development Council, JCDC, of the City Colleges of Chicago, is on track to begin enrolling students for the fall 2026 semester. This announcement marks a historic moment for Black Midwifery Collective, one that represents not only the launch of transformative initiative, but a critical step forward in the systems change required to ensure equitable, community-centered maternity care and advance reproductive justice. Kennedy King College, in collaboration with Black Midwifery Collective, is currently designing a state-of-the-art midwifery simulation classroom and assembling a dedicated staff of faculty, staff, and supporters to ensure the program's success. This historic and systems change achievement marks a major step forward in our mission to diversify and grow the maternity care workforce and to fulfill our vision of a midwife in every neighborhood. The solution is systems change. This program was intentionally designed to create a sustainable pipeline of community midwives, rooting midwifery education directly where it is most needed and long overdue. This historic installation intends to be the first midwifery school in the U.S. located within a predominantly Black community, the first accredited MEC-accredited direct midwifery school in the state of Illinois, the second CPM direct entry midwifery program in the United States housed within a community college, and the only urban public midwifery school in the nation offering financial aid. Next slide, please. Thank you so much. We are open for questions.
Thank you so much, Star. Every time you talk about the new program, I get goosebumps. I'm very proud today to be wearing my Midwife in Every Neighborhood t-shirt in support of the fantastic work that you all are doing. If I could invite Star and Nicollette to come join me on camera for some Q&A. We do have a couple of questions that have come up in the chat. So the first question is from Monica, which is, given that Black women are impacted by these disparities despite age, health, insurance type, income, and education, what do you plan to do differently to support all Black women in this space? And I think the subtext, and there was some discussion in the chat as well, is that a lot of programs are focused specifically on low income or publicly insured individuals, but we know that structural violence affects all women of color.
Nicollette, do you want to take that question, or do you want me to take it?
Star, if you have an answer already, you go first.
Okay, so can you just reread that again? I'm sorry, I was also in the chat as well.
Given that Black women are impacted by these disparities despite age, health, insurance type, income, and education, what do you plan to do differently to support all Black women in this space, not just low income or publicly insured Black women?
Giving us options. If we have autonomy over our body, we have options. You're able to choose where and who you want to give birth with, right? That supports our right, our sovereignty over our bodies. It's a human right to be able to birth where um, and with whom we want to birth with, irregardless of how much, our whether we have Medicaid or private insurance. That should not even be a factor. So that's our goal. Is ideally we really want to have grant as much access to people as possible, and to really set up a landscape that's sustainable to give people access. Like I mentioned in the slide presentation, right? Only 10% of the United States population is deemed high risk and needs to be in the upper level of care. The remaining 90% of our population can actually be seen by a community-based midwife. It's more affordable. We have a higher quality of care. It's really centered on the families that we serve. And it's really meeting families where they are. I think for us, particularly as the Black diaspora here in the United States, we have a very unique story, and we walk a very special path. And it's really important for us, and the data has shown that it's important to have culture congruency of care and have access to that. So once we're removing all of the barriers from us being able to access that care, I think we'll start to see a better improvement in the data that we're seeing. And like I said, once again, it's a human right. We should be able to have sovereignty and autonomy over our bodies, irregardless of the time that we're in, and these different restrictions and the legislative landscape, the political landscape, and everything that's happening currently in the U.S.
Thanks, Star. Nicollette, anything you would want to add to that?
I've also heard from Dr. Kershaw as well, who is in attendance and actively listening. And something that she would like to add is that she absolutely agrees with you, Star. And she does think it's incredibly important to make community-based options available, and that the Earth app in particular offers information that's a great example of how to share hospital-based options.
Thanks, Nicollette. There's another question in the chat about fragmentation of care and how often in hospital settings there is a lot of fragmentation of care. People never even have met the person who actually catches the baby. And if a CNM is involved, they have more personalized care. I'm wondering if you can speak to how more community-based options can help facilitate more continuity of care, more consistent care, so that there's a better relationship between the birthing person and their provider.
So specifically, and I'm speaking on behalf of CPMs as home birth midwives, that really is our focus, right? So we're meeting with a particular client from the beginning all the way through the end. We stay with them 6 weeks postpartum. So 6 weeks postpartum, and honestly, in my phone right now, any baby I've ever delivered, I'm still in contact with their moms and stay, have a very special relationship. So we believe in meeting people where they are. There isn't any fragmented care within a community-based setting. However, it is important for us to work with providers in a hospital in regards to having collaborative care. I'll use an example that I had as I was training as a CPM. So why it's so important to have continuity of care. For instance, I had someone who had just delivered a baby. I was a primary catching a baby, and this mom, after I left the birth, she called me about an hour and a half, 2 hours later, and told me that she was afraid that she was about to hurt herself and her baby. She was having a mental health like episode at that particular time. But because we had built up such a relationship, I had seen her continually through her birth and had a strong relationship with her. She felt comfortable enough to call me to disclose that type of information. When we have patient-centered care, that is really that you really, essentially develop a relationship with someone, it goes a long way in regards to impacting the outcomes for their birth. You're not only impacting that particular person, but you're also impacting their entire family, which then also impacts the entire community when we're talking about, discussing or informing them or educating them on a quote unquote holistic lifestyle, right? Because when we talk about midwifery care, it's not just the the things that we can see in terms of blood pressure, getting their urine, et cetera, fetal heart tones, right? It's also like their mental status. It's also, what they're putting in their body. We're able to go, we go to people's homes, we go in their house, in their refrigerator with them, opening up, going through ingredients, going through food, we're all meeting them where they are, because we understand that all of that compromises the outcomes from that particular birth. So yes, it's really important to reduce fragmentation of care. And yes, sometimes we do have to collaborate with providers in the hospital. So it's important that we have clear lines of communication, support on both sides, so that we're able to better serve our community members. We're better able to have the outcomes that we all desire so much for our families and for our communities. And yeah, fragment of care, like it's something obviously that we're dealing with a lot in Illinois and throughout the US. Hence, there's a lot of siloing. But, through the community birth, the Illinois Birth Justice State Strategic Plan that we're currently working on that you mentioned will be released, we're hoping to address some of those issues.
Star. Nicollette, anything you'd want to add to that?
That was an amazing answer, Star. I agree with everything she said.
Thank you, Nicollette.
And a comment in the chat that in fragmented care, she would have been just told to go to the ER, which would not have been what she needed in that time.
And not to mention, because there's a lack of community-based options, there was a report, I think that I don't know if Arden Handler's on this call, but she sent out a report last night disclosing new data. The utilization of emergency room care, right? Because people can't afford prenatal care, right? It's going up. It's going up. People are going at the last minute. A lot of people don't even really want to have anything to do with the hospital because of the data that's coming out. Like there's something to be said of the fact that there's a high number of people giving birth unassisted. I did for my third birth. A lot of people are very conscious, specifically if you're of childbearing age, of the data and what you're walking into when you go into a hospital system. And so people are utilizing it as their last result. A lot of people would rather, and a lot of the unassisted births have not been documented, right? Some midwives, and I can speak for some of us that are working within a community setting, when we were working illegally underground, could not go in with our clients. And so they had to go in as almost like an unassisted birth as their quote unquote doula, because there has not really been support in regards to the hospital necessarily supporting a community-based setting birth. So the utilization of hospital, specifically the emergency room, is going up because people just don't want to come in contact with. So they wait till the last minute to go in. And yeah, we're seeing, that's not good, obviously, for the outcomes that we're seeing.
So speaking of hospital utilization, there's a question in the chat about what are the options for high-risk pregnancies? Are there any programs that advocate for these women?
I would say like FQHCs and choices where you have continuity of care with midwives in more medicalized settings.
That's Nora Kropp, also from the Black Midwifery Collective, chiming in. There's a question that Nicollette did provide a written response to, but I want to bring it back up because I think it deserves a little bit more conversation. That a lot of what we're talking about in this session is the impact that racism and discrimination and all of these different barriers have, particularly on Black birthing bodies. But a lot of communities face the same barriers and are facing the same challenges. So how can what we have discovered and what you have learned and gathered from focusing on the Black community, how are the findings, how are your recommendations for addressing those challenges also applicable to the broader birthing community in Illinois?
Well, if we are able to address what we're seeing primarily in the Black birthing community, that will improve outcomes for all of us, right? It's a direct tie. So if we really look at making an equitable landscape with quality maternal health care, we'll see an improvement for everybody. But it first starts with centering those that are being adversely impacted the most. I mean, it's 70% of our births were deemed the deaths were deemed, over 92% of the deaths were deemed preventable. That's outrageous. That's outrageous. So let's start there. We do that, everybody will come up.
Yeah, rising tide raises all ships. Any other questions, feel free to drop them in the chat. Otherwise, I will ask my traditional final question of both of you, which is, if someone if you could leave one nugget, one takeaway, one idea for our audience today, to walk away from your session today, what would that be?
I'll let you. I would probably say, I think the biggest thing that's going through my head, and I wake up every day thinking about it, and I know I'm probably out of my time. It's going to take some time for things to shift. I personally, in my lifetime before I die, would like to see more midwives working within a community-based setting. As I said, only 10% of the population needs to be going to a hospital. We need to look at the bigger context. Before there were hospitals, there were midwives. Hospitals is something that's new. It is failing us. We have not gotten past the point of racism being prevalent within our communities. So with that being said, because that's a fact, what do we need to do? We need to restore power back in our communities with people that know us, right? I'm talking about me being able to serve another sister, a person that our children go to school. We go to the same grocery store. There's trust there. I don't have to explain what the lived experience is of being a Black woman. It's unsaid because we have a different walk than anybody else in the world right now, right? Like, we're the highest ones dying of heart disease. Why? Because we're carrying so much. Our hearts are literally bursting. It's too much, right? So just think about that. So when we talk about options, the hospital is not an only option. It only came about because we're in a capitalist society that's based on money. Birth has no place being there. It is extremely sacred. We're talking about the next generation of humans. What is more important than human life? Nothing. Everything else is vanity. So when we have that in our mind right now, we need to really think about, okay, if the hospital systems are failing us, we have all this data. Are we going to sit here and continue to talk about it? Are we going to really start setting up systems in place that are not only going to impact us, but our daughters and our daughters' daughters down the line? Because what's happening right now is not working for us. We're literally being funneled into a system that's murdering us, right? Because of racism, obstetric violence, obstetric racism. That's not going to go in our lifetime. Let's be real. It's not. It's not. So why don't we utilize the time that we have right now to set up a system to serve ourselves? That means anybody that's not on the ground doing the work, coming into this space, receiving funding, send it to us. We need it. We are doing the work. There are several different organizations on this chat right now. I was in a group on a board meeting the other night. We were talking about this. People we've never seen are coming into this space because it's political capital to get funding. But there are Black and Indigenous birth workers throughout the United States, throughout Illinois, doing the work. We've been doing it. Send resources to us so we can serve our communities. Let's work together to set up an infrastructure that supports us, serving us in our communities. That's the safest place, because the hospitals do not have our interests at best hand. They're focused on making money. Let's be real. That's it, and that's all. So if we're not talking about setting up a system outside of that, we will leave our children to inherit that which we don't have the courage to move past right now. I don't care how much money we're making in a community-based setting. It should never come at the expense of human life. Yes, they may, quote unquote, grant us security with retirement, right? As CPMs, as midwives, I don't have a retirement. I don't have a guaranteed paycheck. I have 4 small children, but I bet you this, I know that I'm going to be able to leave this earth knowing that I did what was right, what was just, because this will eventually take place. Everything is shifting. It's just a matter of time. And it really comes down to us removing fear and moving in that way. Right now, we have a limited amount of time. And every time that we delay in making this shift, people are continuing to die. Over 92% of the deaths were deemed preventable. Think about that. That's people dying. That's not a joke. So when we're in this space, I really encourage all of us to really think very deeply about the work that you're doing and how you're really impacting this and how you're setting up a system for people that are coming after us. Community-based options is that's it right there. We need to restore the power back into the hands of our communities. Period, point blank. Industrialized, technocratic systems have no right to be in this space at all.
Thank you, Star. You got lots of agreement, encouragement, and support coming through in the chat and in the emojis here. And I will just say, if you agree with Star's vision and with her message about the power, about returning the power and control for this to the community, please join our next session that will focus on our community-based birth justice strategic plan that was written by community-based birth workers. That is how we are building our power together to restore the strength and the resources that community-based options need in order to best serve community. Nicollette, is there anything that you would want to add as far as a takeaway that you want folks to leave with?
I just want to first say, Star, like, that was such a powerful statement. I can hear the passion in your voice.
Yeah, because we're dying, right? It's real, Nicollette. It's not a joke. And anybody in this space, I feel if you are in this space, you are brought to the forefront to protect mothers and babies. And that's not one that I take lightly, right? Obviously I'm a spiritual woman. It's not one that I take lightly. It's one I think about every day. And you know what we're facing as Black women. We have so much against us, and now we have to be on guard for our womb and for our babies. That's not a joke. So if you're in this space and you say you want to be in solidarity, you want to help us. Help us. Don't just say it, be about it, right? Because our babies are dying. Like, this is not a joke. It's not a joke. It's not a joke.
Yeah. And I just want to quickly summarize what essentially I heard, which is that we need to believe Black women. And we've been saying what we need this entire time, and people aren't listening. I don't think any of this is new information. And that we really do need to uplift those who are doing the groundwork, like Star and the Black Midwifery Collective.
Thank you, Nicollette. Yeah, this is hard work. This is hard work, and it's hard work. And that is why it's so important, is because you all are putting every ounce of who you are and what you have into this work day in and day out. And I am very grateful and very honored to be able to do this work alongside you all. There are a couple other questions in the chat that have come through. We're not going to be able to get to all of them, but I will say that for platforms or resources, we can access birthing rights for our families. Do we know of any? I know that part of our strategic plan is to help develop and publicize those resources so that all birthing people know about their rights, know about the resources and opportunities and choices that are available to them. So that's coming through. And for those of you who are looking for more data, we will be posting the actual reports. If they're not already up on our website, they will be up in the coming weeks as they are published. So you can check back on our website, birthjusticeillinois.org/research, for links to the reports that were referenced today. As we tie things up, I just want to put in another plug.
I'm sorry, Anna, can I interrupt about the birth rights?
Please go ahead.
This is Nora from Black Midwifery Collective. There's the Black Birthing Bill of Rights, Birth Justice Bill of Rights with the National Organization of Black Birthing People. I put it in the chat. And also in Illinois, I just wanted to point out that we do have the Reproductive Rights Act, which does talk about having the right to choose where and with whom you will have birth or receive services. That's an overarching document that I think a lot of people can lean on when arguing certain cases about what our rights are and what we can access. And there's a few other birthing Bill of Rights that I'll just pop in the chat.
Thanks so much, Nora. And this conversation is far from done. So we will be reconvening for the final of the 4 Birth Justice Strategic Plan launch webinars next Friday, same time, same place. We are going to bring back all of our panelists that have talked about the different research projects that they've done over the last year and a half to tie together some of the overarching themes across all of these different projects and discuss how they built the evidence base for our strategic plan. And then we, of course, will walk through the strategic plan in full, talk about what's in it and how you can get involved. So we are here. We are committed to this work. We know that you are too. And you can continue to follow our work. You can move over to this slide. You can join us in our work. The QR code on the right will take you to an interest form where if you're interested in continuing the conversation or just staying in touch, you can get added to our mailing list. And of course, visit our website for more details and information. And I want to thank all of the researchers who participated, the coordinating committee who have guided this work from beginning to end, the strategic plan advisors who lent lots of time and expertise to developing the contents of the plan, all of whom contributed to the research that informed this plan, and our funders who supported our work. And you can view a full list of everybody at birthjustice.org/who we are. And I do want to lend a special thank you again to Nicollette and Star for their time and expertise this morning. And again, particularly to Star for her leadership, for her vision, and for the transformation that you are going to help usher in our state moving forward.
Thank you.
So we hope to see you all next week for the conclusion of this series and the release of the strategic plan. Wishing everybody a wonderful rest of their day and a fabulous weekend. And we will see you all next week. Take care, everybody.